Hello everyone and welcome to another day of high yield USMLE question. Today we will be talking about gastrointestinal. So a 55-year-old male patient with a history of advanced cirrhosis came to the emergency department with severe watery diarrhea and drowsiness. Widely the patient's blood pressure is very low, close to hemodynamic instability. If it is less than 90, it is hemodynamically unstable. But this patient has a very low BP. As expected, there is tachycardia because the sympathetic nervous system is activated, and there is normal temperature. On examination, there are spartangioma and gynecomastia. Remember, this is because of the cirrhosis, and the reason for these two is hyperestrenism. Remember, hyperestrenism does cause vasodilation, so it can cause the spartangioma, pulmonary erythema as well, and also because there is increased estrogen. Estrogen can also cause gynecomastia and testicular atrophy. So now the patient is given IV fluids, and repeat blood pressure is it's very low, so it's very refractory. So labs are as follows: hemoglobin is 11, a bit low, platelets are fine, and WBC is fine. BUN is 80 and creatinine is 2.1. Urinalysis show urine sodium of 7 milliequivalent per liter. No RBC caused the proteins. What is the most likely cause of this patient? Abnormal renal function tests. Right, so we have a lot of options here. We have 4 options here which we need to eliminate to get to the right answer. Remember, the answer here is decreased renal blood flow. This is a case of hepatorenal syndrome. So let me tell you what happens in hepatorenal syndrome. And so remember, it occurs, as the name indicates, it's hepatorenal. It's because of the liver that the kidneys fail. And here the most common reason for this patient is the cirrhosis, the liver. So now if you have, let's say this is the cirrhosis, it's very cirrhotic, it's the blood, and this is the portal vein. The blood cannot go through this, so it gets accumulated in the veins, and it goes here, remember. So this leads to portal hypertension because the blood cannot go through the liver. It's fibrotic and shrunken, so it's a lot of resistance to outflow. So it's going to accumulate here. This is the spleen, so the spleen is also going to enlarge. So these are some features of portal hypertension. Splenomegaly, also because of the increased hydrostatic pressure, this fluid is going to leak out and cause ascites, which is excess fluid in the peritoneum. So this is a few features about just a little bit about the portal hypertension that occurs in cirrhosis. Remember, the other thing that happens in cirrhosis is that increased nitric oxide that results in splanchnic vasodilation. So remember, this is the vessel, the major vessel part that maintains the diastolic pressure, or that maintains the total peripheral resistance, are the arterioles. So the nitric oxide will come here, and they're going to dilate the arterioles. When they dilate that, there is decreased TPR, so total peripheral resistance is decreased. Remember, the major determinant of a systolic blood pressure is cardiac output. The major determinant of the diastolic blood pressure is TPR. Here the diastolic is going to significantly fall, like in this patient. Remember, part of the reason of this low blood pressure is the severe watery diarrhea. Remember, hepatorenal syndrome is triggered by anything that decreases decreases the blood pressure. For example, any hypovolemia case. It can be GI bleed, it can be hypovolemia due to excess vomiting or diarrhea. Here the trigger is diarrhea that trigger the hepatorenal syndrome here. So remember, so decreased TPR. So if there is hypotension, already there is hypotension or decreased TPR in cirrhosis. On top of that, if you give this a trigger, for example diarrhea in this patient, that further decreases blood pressure. This is gonna, because decreased TPR leads to hypotension, and then diarrhea also results in hypotension. This is going to significantly decrease the blood flow towards the kidneys. This results in prerenal AKI. Remember, for prerenal AKI, you have to calculate BUN to creatinine ratio. Here it is around 38, I guess. So that's greater than 20. If it is greater than 20, that is prerenal AKI. So this patient does have prerenal AKI, which is hepatorenal syndrome. So another point that this question mentioned is that this patient is given IV fluids and still there is no response. So that's That's a feature of hepatorenal syndrome, that it usually is refractory. Another thing you need to know is that once you have decreased flow towards the kidneys, some systems get activated. For example, ROS system gets activated. ROS, and what is ROS gonna do? Aldosterone is gonna come and it's gonna cause sodium and water retention. So it's going to further worsen this hypertension, polar hypertension, and those things. Also, it's going to cause excretion of the sodium and also acid. So that's aldosterone, so it's going to maintain that. Also, there is angiotensin that is released, and this angiotensin 2 is going to cause, if this is, let's say, glomerulus, this is the afferent arteriole, and this is the efferent arteriole, it's going to constrict this efferent arteriole in attempt to raise the blood pressure. But the thing is, it's going to further lower this blood flow towards the kidney. This is going to further lower the blood flow towards the kidney. The GFR may not rise because the patient is hypovolemic. So remember, the ROS system gets activated. It's going to cause sodium and water retention. It's also going to cause efferent arterial constriction in an attempt to increase the GFR, but it's going to further reduce the flow towards the kidney. So that's, it's going to worsen it. So then what do you do for treatment? So remember, the treatment, you give vasopressin because of the splanchnic vasodilation, right? The main reason is this. First, you treat the diarrhea. You want to treat the patient's diarrhea. You give albumin. What albumin does is, if you give albumin here, it is going to keep the fluid in the intravascular space, because remember, cirrhotic patients lack albumin. Second, you can give splanchnic vasoconstrictors, so to oppose this nitric oxide effect. For example, you can give terlipressin, octreotide, midodrine. These are all vasoconstrictors, so they are going to raise the blood pressure. So those are some of the, and remember, at the end you may do a liver transplant, because remember, hepatorenal syndrome usually occurs in advanced cirrhosis. So know the triggers of the hepatorenal syndrome, know how to treat it. Very high yield for all the USMLEs. So renal stone, wrong answer. Usually it causes like severe pain, severe flank pain. This patient does not have any, does not have that. Hepatorenal syndrome, again, a wrong answer, and the reason for this is because here usually it occurs after watery diarrhea, and usually there is hemolysis, and they will say, so those features here I'm not seeing. And then immune complex deposition, remember, would cause, for example, it indicates nephritis, right? So there should be some red blood cell costs here. There's no red blood cell costs. Also, I've mentioned here is urine sodium is very low. If it is less than 10, it means it's low. So if urine sodium is low, that's also because of the ROS system activation. So that's further strengthens pre-renal AKI, because ROS system is activated. So hope this video was helpful, and if it helps, and if anyone is interested, they can email me here for tutoring, and also they can email me for my biostat and CCS classes for all the USMLE step exams, CCS classes for step 3. And also, if you like the channel, you can support the channel here. Hope this video was helpful, and see you in the next one.